respected teachers. My topic for today is maintenance PARP inhibitors in platinum sensitive. Now, how do we define platinum sensitivity? It depends on the disease-free interval. Platinum sensitive is if the disease-free interval is more than 12 months. Partially platinum sensitive is if it is between 6 to 12 months. Platinum resistance is less than 6 months. Platinum refractory is that do not respond to chemo at all. Initially, only the disease progresses. Of all the ovarian cancers, 15% have germline BRCA1 and 2 mutations, 25% have somatic mutations, and up to 50%, including the BRCA mutations, show homologous recombination deficiency. Lifetime risk of developing ovarian cancer in BRCA1 and 2 mutation is 50% and 20% respectively. Now there are two types: homologous recombination deficient and proficient. Homologous recombination deficient is seen in BRCA1 and 2 mutations, and other homologous recombination genes are RAD51, PALB2, ATM, ATR, etc. And due to promoter-methylation of RAD51 gene, that is epigenetic silencing. Other rest remaining of 50% are HR proficient. These HR proficient cell tumors have limited PARP inhibitor benefits. DNA is constantly damaged by replication stress, reactive oxygen species, radiation, and chemotherapy, and requires multiple repair systems. Key pathways are base excision repair, homologous recombination repair, non-homologous end joining, and mismatch repair. Base excision repair, it repairs single-stranded breaks. PARP1 and 2 are the central enzymes. Homologous recombination, they are accurate because accurate repair, they lead to accurate repair of double-stranded breaks. Requires BRCA1, BRCA2, RAD51, PALB2, etc. genes. Non-homologous end joining is an alternate double-stranded repair, and it is an error-prone mechanism. And mismatch repair, it corrects the replication error. If mismatch is deficient, if mismatch repair is there, the microsatellite instability is defective. Clinical relevance is that the loss of homologous recombination repair leads to homologous recombination deficiency. HRD cells depend on PARP-mediated base excision repair mechanism, and these are targetable by PARP inhibitors, causing that is leading to synthetic lethality. I'll be explaining that further. DNA damage types and repairs. Single-stranded breaks. The most common form of DNA repair is single-stranded repair. It is repaired by base excision repair. Key enzyme is PARP1, as explained before. And if they remain unrepaired, single-stranded breaks can turn into double-stranded breaks during application. Double-stranded breaks are highly lethal if not repaired correctly. The main repair pathways are homologous and non-homologous. The key message is PARP repairs single-stranded base repair, and BRCA and HR repair double-stranded repairs. So these two systems act as complementary safety nets. In a normal cell, BRCA mutated cancer cell, homologous recombination repair is lost, that is BRCA1 and 2 is effective. It survives only by PARP dependent single-stranded base repair. So in a BRCA mutated cell, if we are giving a PARP inhibitor, PARP is also blocked, that is single-stranded break is not repaired, leading to collapses into that the cell collapses into double-stranded breaks, no HR backup, leading to cell death. Normal cells with intact BRCA can still use homologous recombination to repair the double-stranded breaks, even if PARP is blocked, so they survive. So the key message is that PARP inhibitors exploit synthetic lethality, selectively killing BRCA and HRD positive cells while sparing most of the normal cells. This is a flowchart showing synthetic lethality. What are genomic scars? These are the permanent patterns of DNA damage and chromosomal changes left behind in the cancer cell due to long-lasting effects of homologous recombination repair. Main types being loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions. Significance is that they act as a surrogate marker of homologous recombination deficiency. It predicts the response to PARP inhibitors and platinum chemotherapy. Clinical use is that my choice HRD score, which we are discussing later on, are used to detect these genomic scars. Limitation is that it is a static measure, reflects past homologous recombination deficiency, may not capture the current tumor status or resistance evolution. There are two types of commercially available testing methods. That is, first is Myriad, MyChoice HRD testing. Another is Foundation One CDX HRD panel. This Myriad, MyChoice detects the homologous recombination deficiency using these three mechanisms and generates a composite HRD score. Score is more than equal to 42 is homologous recombination deficient. HRD tumors include BRCA1, BRCA2 mutated and non-BRCA HRD positive. In short, every BRCA1 mutated, BRCA mutated is HRD positive. All HRD are not compulsorily BRCA mutated. There can be other genes also. Other is Foundation One CDX HRD panel, which includes BRCA and LOH assessment. Now there is HRD genotype and versus phenotype. Now what is genotype and phenotype? Genotype shows why HRD exists and phenotype shows how HRD behaves. Genotype is the cause of HRD, defined by specific mutations or alterations in HR pathway genes, example BRCA and or the other genes. And phenotype is a consequence of HRD, which shows functional manifestation of defective HR path repair leading to genomic instability. Clinical implication is that genotype-based testing, BRCA1, BRCA2 mutations are the strongest predictor of PARP inhibitor benefits, and phenotype-based testing causes broader identification of HRD positive tumors, captures non-BRCA HRD patients who may also benefit from PARP inhibitor. Now there we'll be discussing about the drugs, the PARP inhibitor drugs available. First is olaparib. Olaparib, it has approved indications for olaparib include indicated in first line maintenance therapy and relapse in ovarian cancers. Dose is 300 mg twice daily, continued up to 2 years or until disease progression. And most common side effect being anemia, abdominal pain, fatigue, raised creatinine, and rare but lethal side effects are myelodysplastic syndrome and acute leukemia, seen in 1 to 2%, and pneumonitis, fatal pneumonitis in less than 1%. Now, these are few trials regarding olaparib, starting from the first trial, that was study 19. Study 19 was the first olaparib study. I'll be going through these quickly through these trials. Study 19 was the first olaparib study. It was a phase 2 randomized control trial for platinum sensitive ovarian cancer maintenance therapy. Showed BFS benefit and got accelerated approval by FDA for maintenance in 2014. Other trial came with which olaparib was combined with cediranib, which is a VEGF inhibitor, showed PFS benefits and gave strong PARP inhibitor and VEGF combination signal with increased toxicity. Then came solo trials. Solo 1 trial was a phase 3 RCT placebo controlled, given in first line maintenance, which decreased the risk of progression by 70% and had a better significant median PFS. So FDA approved it for frontline therapy for advanced ovarian cancer in 2018. Another trial was Solo 2 trial published in 2017. Again, it was a phase 3 RCT. It was a maintenance for use in maintenance therapy for relapse in ovarian cancer. Solo 1 was for first line maintenance. Solo 2 was for relapse maintenance. It again showed progression-free survival and OS benefit, which led to FDA EMA confirmed approval of BRCA mutated relapse. Medulla trial, it had 2 parts. In original Medulla trial, olaparib was combined with durvalumab, showed a good disease control and overall response rate, and showed good activity of PARP inhibitor with immune checkpoint inhibitor combination, but it had only one arm. Later on, olaparib was combined. The olaparib and durvalumab arm was bevacizumab was added to it, and the triplet therapy DCR and ORR and PFS benefit. This triplet paved the way for large RCT, though it is not practice changing as of now. Solo 3 trial was a phase 3 RCT in platinum sensitive relapse, in which the olaparib was compared with non-platinum chemo, that is PLD, gemcitabine or topotecan. Olaparib showed better ORR and PFS, but no OS benefit due to crossover. Another landmark trial was Paula 1 trial, phase 3 RCT, in the first line using first line maintenance, in which maintenance therapy was compared. Bevacizumab alone was compared with olaparib and bevacizumab. In advanced ovarian cancer, HRD testing was done using Myriad, MyChoice, and better PFS was seen in overall HRD positive patients, which led to FDA EMA approval in HRD positive advanced cancers. Light trial was again reinforced. The light trial came. This again reinforced the biomarker driven approach, that is BRCA mutation and HRD status. Oreo trial, as the name suggests, it was olaparib re-challenge trial, showed modest PFS benefit in BRCA-mutated ovarian cancers in previously received PARP inhibitors. And this again, Duo trial was published in 2023. It was a phase 3 double-blind RT. First line maintenance. There were 3 arms in Duo: chemotherapy plus bevacizumab followed by bevacizumab maintenance, chemo, bevaci, and durvalumab followed by durvalumab and bevaci maintenance. And the third arm was chemo, bevaci, durvalumab earlier given, and later on durvalumab, bevaci, and olaparib maintenance. The triplet, this is the third arm, significantly prolonged progression-free survival in HRD positive patients. It was the first positive trial trial in first line maintenance. The overall final results are still awaited. Next in line is rucaparib. It is again indicated in first line maintenance therapy and relapse. Dose is 600 mg once daily. So common side effects being nausea, anemia, fatigue, transient activity rise, creatinine raise, and MDS and AML in less than 1%. Few trials regarding rucaparib was study 10 was the first in human phase 1, phase 2 dose escalation trial. Aerial trials are related to rucaparib. Aerial 2 was a phase 2 single arm. The patients were divided into BRCA mutated with LOH high and low. Maximum PFS was seen in BRCA mutated patients and got accelerated FDA approval for treatment, which was later on withdrawn in Aerial 4 trial due to no OS benefit. Aerial 3 trial, 3 biomarkers was used, that is, patient were divided into BRCA mutated, HRD positive, and intention to treat population for maintenance in platinum sensitive relapse. All groups showed PFS and benefits, and led to FDA EMA approval in 2018 for maintenance in platinum sensitive relapse. Aerial 4, in which the rucaparib was compared with chemotherapy directly for treatment in relapse in BRCA mutated ovarian cancers. Overall survival was worse, so FDA withdrew the treatment indication in 2022, which was already accelerated treatment approval was given in Aerial 2, withdrawn in Aerial 4. Athena mono trial was an important trial. It was a phase 3 RCT. The first line rucaparib maintenance therapy. The patient was stratified as BRCA positive, HRD positive, HRD negative, and maximum PFS benefit was shown in HRD positive patients. But HRD negative subgroup also got modest benefits, so it was established as an effective first line maintenance irrespective of the BRCA status. Final mature results, overall survival results are still awaited. FDA approval is also waited for the same. In Athena combo trial, the rucaparib was nivolumab was added to rucaparib as first line maintenance, but found no added benefit. Atlas trial also showed that rucaparib does not show benefit in heavily treated patients with recurrent disease. Next in line is niraparib, indicated for first line recurrence and maintenance therapy. Dose is 200 mg once daily. If body weight is less than 77 kg and less than 1.5 lakhs of platelet counts, this is the initial starting dose, and otherwise 300 mg once daily. Side effects being most common being thrombocytopenia, anemia, neutropenia. Hypertension is unique to niraparib. Trials include ANANOVA 1 that established the dose, ANANOVA 2 confirmed the biomarker gradient for niraparib, that is BRCA positive, HRD positive, and HRD negative. NOVA trial was an important trial. It was a phase 3 RCT placebo controlled, tried for maintenance in platinum sensitive ovarian cancer, showed a better progression-free survival in BRCA and HRD positive mutated patients, but also showed modest benefit in HRD negative patients. It led to 2017 FDA accelerated approval for all comer maintenance, that is irrespective of HRD and BRCA status. Quadra trial was a single arm phase 2 with previously more than 3 lines treated with, that is heavily pretreated cases, including platinum sensitive, platinum refractory, and resistance cases. It showed maximum overall response rate in patients, which led to 2019 accelerated approval for treatment in pre-treated HRD positive tumors, which was later on withdrawn in 2022 after the final results due to no overall survival benefits. Primer trial came in 2019. It led to niraparib to get FDA approval for all comer first line maintenance, double blind RCT, placebo controlled for first line maintenance, showed PFS benefits in HRD positive patients and moderate benefits in HRD negative patients. NORA trial led to the creation of individualized starting dose, that is less than 77 kg and less than 1.5 lakh platelets, 200 mg starting dose and above 300 mg. Ovarian trial was used niraparib with bevacizumab like Paula-1 trial and got supportive results, but not practice changing as it was a phase 2 single arm study only. The PACIO trial showed niraparib and pembrolizumab and modest benefit in platinum-resistant ovarian cancer independent of BRCA status. Moonstone trial was a negative trial. Niraparib was combined with dostarlimab, but trials stopped due to no benefits. These olaparib, rucaparib, and niraparib are approved globally. Veliparib, in Velia trial, Veliparib was concurrently given with platinum taxane chemotherapy and continued as maintenance, significantly improved PFS in BRCA-mutated and HRD positive ovarian cancers, though not adopted as standard due to modest benefit but when overlapping toxicity. In China, pemiparib and fluzoparib have been approved in BRCA-mutated cancers. Talazoparib has breast cancer approval, but ongoing ovarian trials are there. It is the most potent PARP trapper, but has the maximum adverse event. Now, this is a flowchart on how to choose a PARP inhibitor for first-line maintenance therapy. If bevacizumab, we have to see that if bevacizumab is being given, is bevacizumab is not being given in first-line maintenance, but patient is HRD positive and BRCA mutated, we can give all three: olaparib, rucaparib, and niraparib. Out of all these three, rucaparib has not yet received FDA approval, but in NCCN it is approved for it is approved based on Athena mono trial, which is a 1B level of evidence. And if the patient is HRD negative, either we can give niraparib and rucaparib, and if bevacizumab is being added in the patient is HRD positive and we are commutated, start bevacizumab with olaparib for maintenance first line based on Paula-1 trial. And if the patient is HRD negative, give only bevacizumab based on GOG218 and ICON-7 trials. Second flowchart is for how to choose a PARP inhibitor for maintenance therapy in recurrence. In case of PARP inhibitor relapse, PARP inhibitor, how to choose a PARP inhibitor? PARP inhibitor decision will be based on bevacizumab decision. If prior bevacizumab was given to the patient and the patient did not receive PARP inhibitor, we can start any of the three, olaparib, rucaparib, and niraparib to that patient. And if prior bevacizumab has not been given and patient has received PARP inhibitor, give only bevacizumab based on GOG213 and GOG213 and Ocean's trial. Oreo rechallenge has been olaparib rechallenge has been tried in Oreo trial as discussed before. Now, for FDA approved PARP inhibitor in cancer, first line maintenance and recurrent maintenance. First line maintenance, olaparib has been approved for FDA approval for first line maintenance based on SOLO-1 trial. Niraparib in all comers, that is irrespective of HRD or BRCA status. Niraparib can be given, and if we are giving bevacizumab to the patient, olaparib has been approved. And in recurrent maintenance, all three, ola, ruca, and nira can be given. They have all the three trials, all the three drugs have FDA approval for the same. Now comes mechanism of PARP inhibitor resistance. Once a homologous recombination deficient has now become a homologous recombination proficient cell again, leading to the PARP inhibitor resistance. It is seen in 20 to 30% of BRCA-mutated cancers, leads to cross resistance between PARP inhibitor and platinum, detectable by circulating DNA. Switching PARP inhibitor in these cases is ineffective, and we have to consider ATR check inhibitors or DNA protein kinase inhibitors and immunotherapy-based combinations which are under investigation for this. Key take-home message being, PARP inhibitors have redefined survival outcomes, and future is in smart combinations, resistance reversal, and real-time biomarker-driven therapy for better results. Thank you.
The talk is open for discussion. Any questions from third year, first year, and second years? Let's take them one by one.
Hello, Paras. Can you just explain how that PARP inhibitor rechallenge can be justified, or in what cases we can give that rechallenge PARP inhibitors?
It was tried in Oreo trial published in 2021. In this case, the olaparib showed more benefit. PFS benefit was modest. You can see in the slide also. it had a PFS modest benefit in BRCA mutated, and even non-BRCA mutated also it has a modest benefit. So it can be tried, but it has not got still a FDA approval for the same.
Paris, hello. Is
Yes,
olaparib given in all stages and all histologies, or there are specific stages in histology you give olaparib?
no, it cannot be given. It cannot be given in low-grade serous carcinomas. It can be given in endometrioid types and clear cell carcinomas, and also carcinosarcoma of the ovary, and high-grade serous carcinoma of the ovary.
So the question, Paras, actually was, what are the indications of
Sir.
PARP maintenance? Indication of
Sir, if
PARPi
the patient,
maintenance.
yes, sir. So both for first line and sir, later on, if in the case of recurrence, when the patient has responded to partial response or complete response, the patient has responded to the first line management. Patient underwent NSCT followed by surgery, or surgery followed by chemotherapy. Now the patient has completely or CA125 levels are normal and disease is completely under control.
Paras,
We can keep the patient. Yes, sir. Yes.
Should all
Yes, sir.
cases undergoing chemotherapy be given maintenance, or only a select population requires maintenance?
Advanced ovarian cancer.
That is offering.
Advanced
That is
ovarian,
offering
stage 2 to
question.
4. Advanced ovarian cancer, sir. Not early ovarian cancer. It is recommended
was
only
another-
for advanced ovarian.
There was another question coming
Yes.
from audience. Yeah.
Why can't we give PARP inhibitors in non-epithelial ovarian cancers?
Googly Paras.
It can be given in carcinoma sarcoma type. Actually, the homologous recombination is not seen in those cells. So it is seen only in or only in epithelial ovarian cancer cells. So that can be one reason, sir.
Any other question?
Hello.
Sir, why we cannot give PARP inhibitors in platinum non-sensitive groups, all the three rest of the groups?
Pardon?
Platinum non-sensitive groups. The resistant.
That is, you are asking about platinum resistant cases.
Yes.
Actually, platinum resistance itself indicates that there is a restoration of homologous recombination repair or alternate resistance mechanism. So PARP inhibitor will be less sensitive to those in these cases. So we are not giving PARP inhibitors.
Nancy, the answer to this question is in the mechanism of tumor killing by platinums. They act by DNA adduct formation, leading to DNA damage.
Okay, sir.